Well, good morning. Thank you, everybody, for being here. I do explain to Dr. Baum, our guest of honor, that this will be live streamed and recorded. And you come during the week where most everyone in Michigan goes on vacation. But I guarantee you, my friend, that this will be sought after because it is a blessing to have you here. I had a chance to go to dinner with Professor Baum, and Dr. Chang will introduce our guest speaker, but you're all in for an incredible treat. I want to give a quick shout out to our friend Doug Meyer. Those of you that have seen the beautiful piece of art by the Research Center, that was made possible by Doug and his passion for behavioral health as well as cancer. It's a gift to our community, so thank you, Doug. It's my pleasure to introduce my friend, Anthony Chang. Anthony is someone who is visionary and sees no limit to the possible. No limit to the possible. So just as a fun example, when he was in Taiwan, he said, I think I'd like to be a national champion in martial arts. And so then he did, which is remarkable. He got his undergraduate degree there at Changgung University, bachelor's degree there. Then he came to the United States and did biomedical imaging training both at Vanderbilt and then Yale, and then went on to get a PhD in medical physics at the University of Texas, San Antonio. So Dr. Chang. He had a vision of redefining how medical imaging and therapy could be done. That brought him to our community, Grand Rapids, which again is a blessing for us. When I had a chance to meet Anthony and I heard about his dream and what he thought was possible, it nicely aligned with what brought me back here. So this collaboration with Rethink Imaging is something I'm really excited about, and again, really glad to introduce my friend and colleague, Dr. Chang.
So good morning. Welcome bei MSU. En danke Beauchamp. Ik ben Dr. Anthony, and welcome to MSU. So it's my great pleasure today. That's pretty much all the German I can speak. I really appreciate Dr. Baum's support and for this event, especially, and I also want to appreciate Doug Meyer's support this whole event to make this happen, and especially I want to appreciate Dr. Baum and Ms. Baum in your tight schedule to arrange this trip and give a talk to us over here. This is actually a very unique introduction for the talk, because this is the second time I have used PowerPoint to introduce our speaker. Last time was Michael Phelps, Dr. Michael Phelps, and he was the inventor of the PET. And when I read his CV over 40 pages, I was like, I need to get a degree for that. And so, but a little bit different for Dr. Baum. Let me talk about how I know Dr. Baum. Is actually last February, I actually have a chance to go to his clinic to get involved in the clinical procedures and start to see the theranostic process. And this is actually the Facebook page. After finish a week of work with him, I post on my Facebook. The whole week is cloudy. It's in the winter in Germany, and the Friday, all of a sudden, the sun comes out. And after finish all the reading, all the tests and procedures, at 3 p.m. in the afternoon, I sit in the lobby of the hospital, and I was just shocked. I was like, what have I seen this week? What has just happened? Because there's so many information. I mean, I'm in molecular imaging field for a long time. I'm in theranostic field for a long time. I'm a deep believer over there. I read a lot of paper. There's no doubt about it. But when you really see the outcome of a patient, how people really apply this technology into the patient, and over there it is a routine instead of just a clinical trial. And the patient, the life quality of patient is so different, and that really shocked me, and that gave me a lot of motivation make me feel like no matter how hard it is, we have to bring it back to United States. We have to make it more accessible to more patients. Dr. Baum is very, very inspiring. I mean, since then I'm working with him closely. I mean, I sent him an email at 9 p.m. during the night, which is 3 a.m. in the morning. 5 minutes later, I got a reply. And it's constant all year long. And I really, one thing I really respect Dr. Baum is he's really, really patient-oriented. He's willing to sacrifice everything for his patient. His vacation time, his like nighttime, everything will not, he will do everything for his patient and the best for his patient. And the other thing I think I really learned from Dr. Baum is his selfishness. I mean, he's always continually trying to willing to spread the words to these technology to any part of the world. And a lot of countries send their doctors to Germany, to his clinic, to learn this technology. And he just teach them like selflessly. He will not try to hide anything. He wants this technology can be available to more patients. So let's take a look about this is some photos I have with Dr. Baum. This is just a great time. Dr. Baum is actually the chair and the clinical director of the Theranostic Center for Molecular Radiotherapy and Molecular Imaging at the Central Clinic, Bad Berka. He is actually the godfather for Theranostic field. He did so many clinical trials, first in human clinical trials, and he actually is the person who did the most theranostic procedures on neuroendocrine tumor, and he is the person did the most PSMA theranostic trials in clinic, and the cohort is the largest in the world, and he's the first person doing lutetium PSMA study. So a little bit different from Dr. Baum's CV and Dr. Phelps' CV is Dr. Phelps' CV actually have 45 pages. Dr. Baum's CV, when I asked the CV from Dr. Baum, I actually looking for another 45 pages things, but it's actually only 4 pages and mic drop. So this is actually what Dr. Baum do. I mean, I just have this award, and let's take a look statistical of a publication I have. I gave more than 1,000 talk. I published over 1,000 abstract, and I have more than 500 published papers. So I don't want to occupy too much time. Again, welcome and thank you for coming to Grand Rapids to share your research with us. And let's welcome Dr. Baum.
Thank you very much, Anthony, for this very kind introduction, and also for spelling Bad Berka correctly. Okay, it's actually not bad at all. Bad in Germany means spa, and it's a very nice region, as you will see. And I would like also to thank Doug Meyer for supporting our travel to here, and all the people I met yesterday. Very, very exciting time here. I'm really very impressed by Grand Rapids and what you have achieved over the last 15, 20 years here, and it's ongoing. So today I will speak about personalized cancer therapy from innovation to implementation. And I will use PSMA radioligand therapy as the example how to do that. So in Bad Berka, we have actually ENETS Center of Excellence, and that means that we have a qualified procedure to get such a center of excellence, which includes many disciplines. And I think this is one of the first statements I really would like to make, is that if you want to be successful in this area, you should really collaborate very closely with your colleagues, especially, of course, with oncology, but also with other fields, radiology, for example, interventional radiology, and also surgeons, and basic sciences. Unfortunately, the images are here missing from our center. I don't know why. But we are seeing about 800 prostate cancer patients per year. So we do not have a dedicated uro-oncology department in our center. That just shows you how this method of imaging prostate cancer and of treating prostate cancer with PSMA ligands is really attracting patients. So this is our motto, passion for precision. And, I don't know why it's not working. It's not showing the images. Well, these are shown, but the others are missing. Okay, let's go on and try. If more are missing, I have to use my own computer. But this is a map showing actually the world and the continents and where the patients are coming from for peptide receptor radionuclide therapy to our hospital. So we have from all continents and over 100 sites. This is the statistics showing you that we have around 80 to 100 over the last 5 years, but then we have a jump, a nearly doubling when we introduce PSMA radioligand therapy, showing again that this is a very, very attractive treatment modality. We have what we call a Theranostics Research Center, and this is just a rough structure of such a center where you let's go on, okay? If it doesn't work, we can change it. We just need molecular imaging, so you need PET-CT or PET-MRI, you need novel tracers, you have clinical studies, all what you have here already available, okay? And BBQ MIT actually is a quantitative method for image segmentation and extracting information digitally from images, which we created more than 10 years ago. I will show you later. And then we have, of course, molecular therapy, which includes also medical physics, again, clinical studies, multi-center trials, dosimetry, and so on. And preclinical imaging we are doing in collaboration with other centers, especially currently with the Paul Scherrer Institute in Switzerland, where there are more than 500 people working in this field. And we have a very good molecular pathology lab. And I was very impressed again yesterday by seeing what you have available here. So you have most of these already here, right? What you really need is a dedicated cyclotron, I think, for doing, new tracers like gallium, like copper-64, zirconium, and so on. And a structure for implementing therapy, that's most important. So, no, we have to change the computer. I mean, it's not showing the images. I mean, they are shown here, but they are not showing up when I... it was actually this one here. This one here? Yeah. Okay, thank you so much for your help. Yeah. So this is again the map I mentioned, and we have started in 2011. As you can see here, we had the first Theranostics World Congress in Bad Berka with people from 56 countries. And the second one was in India, the third in United States, actually at Johns Hopkins, where you also have been with our good friend Marty Pomper as Congress presidents. At the time, Richard Paul was just leaving, so they joined actually the presidency. And then 2 years ago in Melbourne, in Australia. And the fifth one will be next year's at the beautiful island of Jeju in South Korea, March 1 to 3. So if everyone is interested, it's actually a very powerful congress with a lot of good speakers, but it's also a very nice surrounding, so you can also enjoy it. So this I have mentioned already. So Theranostics means a combination of diagnostics and therapy, and the whole concept was created really originally by my personal star, which is Paul Ehrlich. Paul Ehrlich was a pathologist, and he received the Nobel Prize in Physiology or Medicine in 1908. And why he is my personal hero is because he was a very creative man, right? And from very simple observations, he came to really groundbreaking concepts. So you all know, and every medical student know, hematoxylin eosin, HE staining, okay, which was invented by Paul Ehrlich. Nobody knows about that, but it's a fact. And he was called the painter because when he was running around with his white shirt, it was always covered with different colors because he was staining all these tissues. So he worked not far from the place where I was born in Strasbourg. Yeah, I'm born just 80 kilometers away from that. But he also was in Berlin and got a own institute by the king at that time, Königliches Institut für Serumkrankheiten. And he actually, from his observation of the fact that colors are binding to tissue, he came to the concept that also a drug could bind specifically to a bacteria or virus or to a tumor. And these are hand drawings, what you are seeing here, by Paul Ehrlich, okay? And it's a little bit like Jules Verne, okay? How could Jules Verne imagine that we travel to the moon, right? Okay, I think 100 years before it happened. And the same is with Paul Ehrlich. So how could he imagine that we have tumor markers? You see, the cell is secreting tumor markers. How could he imagine, if you look at the drawing, that exactly this fit, what we call antibody-antigen imaging or radioligand-ligand combining, really happens? I mean, that was really genius. And he made a statement in Latin, because at that time every professor had to speak Latin, corpora non agunt nisi fixata, which means that substances are only working, compounds are only working if they are binding, you know, to the cell or to their object. And the German word Zauberkugeln, magic bullets, I mean, was used 90 years later, but it's still in our head. And we are working today actually with magic bullets, okay? So another one I would like to mention is Saul Hertz, who is a father of radioiodine therapy, which was applied more than 75 years ago. And it was actually the first application of theranostics in history and the cornerstone of nuclear medicine. And it is very, very successful. Why? It is effective, okay, it is affordable, and it is practicable. And these are the three characteristics for any new approach. Affordable, which is very, very important, especially in this country, right? Because many of the new drugs which are used are, you know, have some financial toxicity, okay? And you have to think about, you know, what we can afford in the future and what our health system will be able to afford. But it must also be practicable. Now, radioiodine is done all around the world, right? In the, you know, darkest part of India or in South America or elsewhere, you just take a few drops of radioiodine and the patient is drinking it, and wow, here is the effect, okay? So this was actually the first patient I treated in Bad Berka. I have treated thousands of patients with thyroid cancer. This was a specific first one in Bad Berka, and she was actually a young lady and palpated a nodule when she was delivering her first child, right? And then we diagnosed her, as you can see here on the right side, with more than 100 lung metastases, okay, which was unfortunately overlooked during her pregnancy. And we treated her 3 times with radioiodine, and she got, as you can see here, a complete remission of the disease. And after radioiodine therapy, she delivered healthy twins, and later on another child, okay? So she has 4 children, and the most important, she is healthy and without any disease today. I have seen her just a month ago, and this is something I think nuclear medicine is doing wrong. It's not really announcing and, in the right way the success stories we have to offer. If you would have a treatment, chemotherapy, which is curing metastatic cancer, it would be on the title page of Washington Post or I don't know, okay? But nuclear medicine is not speaking about their successes, and this is not good. So I would like to go a little bit more forward with what is theranostics. And it actually starts that you observe a disease, okay? And then you take action. Let's say you diagnose cancer, and then you do chemotherapy, and then usually after 3, 4, or 6 months, you are re-evaluating, you are restaging. Okay, so it's working, let's say in 70 or 80% of the patients, but in 20% is not working. So it's really we have data from large studies, sometimes in over 1,000 patients. But for the individual patients, when he goes to his oncologist, he cannot promise you if it will work, if you are the 20% or the 80%. And this is what we can change with this approach of theranostics, that we observe the disease and then we insert a test. And in most cases, this test is molecular imaging, will be PET-CT, to show if your target is really there. And then you take action. And then you have a predictable response, okay? Because if your target will be there, you can really do what we call precision oncology. You can precisely choose from the available compounds which one you will use to treat the patient. And not only the compound can be chosen, but also the radioisotope nowadays can be chosen. So if you have big tumors, right, you can probably use a harder beta emitter like yttrium-90. If you have small tumors, you can use lutetium or alpha emitters. So we have some flexibility also in the radioisotope we are using today. And one very nice example how this method works and how you can come from bench to bedside is actually peptide radionuclide therapy for neuroendocrine tumors. Now this is another pathologist, and I think he is somewhat similar to Paul Ehrlich, right? So he has not received the Nobel Prize up to now, but he deserves it in my view. He has characterized 90% of all targets we are using nowadays in theranostics. And this is Jean-Claude Reuby from Switzerland. He worked for a very long time in Bern. And this is from 1984 and shows you iodine-125 somatostatin autoradiography. So what you are doing is that you label your small peptide with iodine-125, you incubate it with a tissue, and then the peptide binds to the receptor, and you can show this by this autoradiography. Okay? Now, if a nuclear medicine sees iodine, okay, immediately you think, how can we translate this, from in vitro to the patient by using iodine-131? And that's what the group actually in Rotterdam did. But it didn't work because the peptide with the iodine was not stable. So they choose indium octreotide, which is another version, and which actually worked and showed tumors in vivo. And also at the very beginning, this Auger is also an Auger emitter, indium-111, was used for treatment, but was not very successful. But just showing you the principle again, okay, from bench to bedside, from tissue to treatment. And this is probably the most important slide for your understanding of the whole concept of theranostics. It is, in a short form, we see what we treat, and we treat what we see. And it's working like a key and a lock. Okay, so on the cell, we have our lock, which can be antigens like CD20 for radioimmunotherapy, can be Herceptin We can label nowadays trastuzumab with lutetium and treat breast cancer. Can be GPCR, G protein coupled receptors, which actually is another Nobel Prize just a few years ago for a chemist who detected this principle of these G protein coupled receptors. And somatostatin receptors are one of the examples. Or what I will discuss today is PSMA, an enzyme, or it can be enzyme inhibitors we are using, or transporters, or many different structures on the cell surface. And then we have the ligand, which binds like a key into the lock. And again, we have a great flexibility. We can use antibodies, minibodies, affibodies, regulatory peptides, or PSMA ligands, which is just a urea compound. Very small molecule, but just fitting in this pouch, okay? And again, I think in Grand Rapids, you have great potential, right? You have a lot of these substances which are used already in the laboratory, in animals and so on, but you have, I think, to go to humans. And then we have a linker which is connected to the ligand, and a chelator, which is a small cage. And in this cage, the radioisotope, is inserted and kept there very, very stable. So if the isotope is in the cage, in the chelator, it does not escape when you inject it into the body. And this is, of course, very important because you want to have your key really fitting in the lock together with your label. And this is, in our case, mostly gallium-68, which is a short-lived positron emitter of 68 minutes half-life. Or it can be F18, which is used most frequently also in the city, like FDG, fluorine 18 fluorodeoxyglucose. Or we can use also cytotoxic units instead of a reporting unit. Instead of imaging, we can use, for example, lutetium, which is a beta emitter of 6.7 days half-life, or alpha emitters like actinium, which has nearly 10 days half-life. Okay, so this is a principle, and this is part of really personalized medicine and precision medicine or precision oncology, which starts, for all the students listening, with something very simple, like taking patient history, right? Many doctors are today not, excuse me if there's a radiologist I know in the room, but radiologists are hardly speaking to patients. And you are lacking a lot of very valuable information from that. And I think in the time where we have Facebook, where we have iPhones and so on, one have to find new ways to get you all of this information. Patient history is really, really important. But also other things, proteomics, metabolomics, gene expression profiling. You do everything here, right? I heard yesterday several 10,000 tests, for gene expression profiling and so on, routinely. Okay? What you have to do, and what we all have to do, is to connect this information with our PET-CT or PET-MR, so we have really a precision oncology. We can look at structure and function with the information from the cell. And that will give us the opportunity for, selecting the patients for the right therapy, for monitoring the disease, for early diagnosis and risk assessment, and in future, I think even getting epidemiological or prevention data from that approach. So in Bad Berka, as you have mentioned kindly, we have really the largest series of patients treated with neuroendocrine tumors, which is a rare tumor, but known to many as a disease of Steve Jobs, who had a neuroendocrine pancreatic tumor and unfortunately went to Mexico to a healer and not to our center for treatment. Otherwise, we would probably have a better iPhone today, I don't know. But we have treated more than 1,500 patients with now 5,700 cycles of therapy using lutetium, yttrium, and also alpha emitters. And this is the first patient I treated in Bad Berka back in 1998. And I will show him because it's nearly to the day I treated this patient 20 years ago. He was a young boy with a paraganglioma, which is an even rarer tumor of the neuroendocrine tumor subgroup. When he was diagnosed in 95, he was 15 years old. He had actually, when he came to me, received chemotherapy and radiation therapy and all kinds of therapies, and the oncologists say, take him. I can't do anything anymore. Anyhow, he will die within the next half year. And you see his miserable status. And these are some of the images. At that time, we were still working with indium-111. In this case, DOTA-TOC, we injected before the therapy to see our targets, the diagnostic approach, right? Imaging, target is there, and then you can use it for treatment. And we treated this patient several times. And in June 2000, so 3 years after start of treatment, not 6 months, he was still alive, smiling, much better. He gained weight and so on, but he could not walk. You see, he's sitting in a chair because he was wheelchair bound. He had a metastasis in the spine and due to this tumor. And then we decided I decided to ask our radiologist, our interventional radiologist, could we do a treatment directly of this metastasis? And he said, okay, it's not easy to go to this lesion in the spine, okay, but we will try by super selective catheterization. And we then injected 50 millicurie, 1.8 gigabecquerel of activity into this metastasis. And what happened really changed his life and also in some way my life, because he started not only walking, he was even able to play football and make his driving license and so on. So he returned to a nearly completely life, you know, and this is 2003, 6 years, you know, after the first treatment. And he unfortunately died, but not of his disease, but due to a dentist who extracted a tooth in the maxilla, and he got an infection and an abscess and paralysis of the glossopharyngeus nerve and died of aspiration pneumonia, right? So this happens. But anyhow, I was so impressed by this first patient. It's the index patient for me that, okay, we have to go on this way. And it is a long story from these first experiences, which were also, of course, made in Basel, which is a world-renowned center for this kind of therapy, and actually was the first to use DOTA-TOC with yttrium-90, and then later on in Rotterdam with the 177 lutetium, okay, and in 2012 a phase 3 trial started, which was completed in 2016 and published in the New England Journal. It's a real landmark publication in theranostics. And shortly thereafter, this is just one patient from this treatment series. You see you have liver metastases. If you count them, more than 20 actually, up to 5 centimeter in size. And 3 years after 3 cycles of PRLT, there is complete remission of the disease without any sequelae for the patient. And that led to approval actually first in Europe, by the EMA, and in January this year also by the Food and Drug Administration. So this is approved in this country, okay, but the experience is quite limited, okay, and it's, I think, also a chance for you here in Grand Rapids to start not only with this treatment, but with similar treatments like with PSMA I have mentioned. Just a few days ago, we published a paper in the Journal of Clinical Oncology on the health-related quality of life of these patients. And I think this is as equally important as prolonging life, is to improve quality of life. If you would be the patient, you know, you would, and you live longer, you would like to have a life with a good quality to live longer. And this is proven as compared to high-dose somatostatin, which was a comparator, 60 milligram centostatin every day, and you see that there is a significant improvement in all parameters for lutetium therapy. So this therapy is really well tolerated by the patient and improves the quality of life. Now we have some special German skills, which is to compose classical music. I think if you think about Germany and you ask what is really essential, I think classical music like Bach and Beethoven and so immediately comes to your mind. Playing soccer, we will see. I mean, we are the world champion, right? We have the German gladiator about 4 years ago. I'm not sure if this time we will be as successful. At least Mexico showed us there are some limits, okay? And then we can brew beer. And I was very impressed by this city, okay, seeing so many breweries and microbreweries and a lot of good beer. So, but we have also very gifted chemists, and I think radiochemistry is one of the strengths of Germany. So the image of the year and many other things. The gallium generator actually was by my friend Frank Rösch, not invented. It was invented in the United States by Tucker some 50 years ago, but the method to use it clinically, you know, as a clinically established system, this titanium oxide-based method and extraction method, that is what Frank Rösch really did. And you see in 2004, we have done over 12,000 studies with gallium in our center. So it is an absolute routine. And this is something very important. And this is actually Frank Rösch shown here. And the other one is Hans-Jürgen Wester in Munich. He also has a small company, a spin-off, which is called Syntomics. And this shows you how today, you know, a positron producing factory, which was, you know, a billion or $1 million investment in the past, can be cut down to a very simple refrigerator size of production with this gallium generator. So these are the first prototype we were using in Bad Berka, and today this is all established as a pharmaceutical routine. These are some of the tracers by Hans-Jürgen Wester, labeled with fluorine and gallium. And you see, it's not only cancer. There are many other interesting applications like angiogenesis, opioid receptor imaging, and so on and so on. And one example I would like to show is CXCR4, which is a chemokine, okay? And when labeled with gallium, it's called Pentixar4, which can be used for malignancies like myeloma, lymphoma, acute myelomic leukemia. Very, very nice and specific imaging. Totally different to FDG, right? I mean, FDG is the workhorse. It's used in 90% of all departments, but it is in some way really unspecific. You always have to question it if there is some inflammation, ongoing granulomas and all of this. No problem with this tracer, and it can also be used, the same compound, in solid tumors like pancreatic carcinoma, adrenal, breast cancer, small cell lung cancer. This is one example from our center here, because we have been the first in the world to use this compound, not only for imaging, but also for treatment. Initially with iodine-131, and later on with lutetium and yttrium labeled. But it is also useful in non-small cell lung cancer. So it's a really very interesting compound. And this shows you a treatment which was actually performed at the University of Würzburg in Germany in a patient with myeloma who had failed all other treatments. And these are follow-up scans with FDG showing you the widespread metastases. The patient was then receiving a stem cell transplantation and then was treated with Pentixar4. And you see that there is complete remission of this widespread disease. So quite a successful treatment. And what is even more interesting, that there are applications beyond cancer, like myocardial infarction, atherosclerosis, and stroke. So I think this would be an ideal agent to start here a clinical trial, okay? Because you have all these different features and maybe interest from different sites to use it. Okay, so gallium really was very, very essential to make this concept of theranostic successful. And again, as shown here, it's not only tumor, right? It's hypoxia, it's angiogenesis, it's many other things, and the use of gallium is growing and is really exponential over the last years. So for the future, I think that precision oncology means that cancers will be not anymore classified by molecular phenotypes. So nowadays we are speaking about lung cancer, pancreatic, breast cancer, and so on. But in future there will be molecular phenotypes used, like HER2 expression, like somatostatin expression, PSMA expression. And these phenotypes can be easily determined by molecular imaging, and then treatment will be targeted against the specific tumor of the patient. And this is really, in fact, what we call precision oncology, okay? We just have to integrate also the data from genomic studies and so on. So prostate cancer is really a paradigm for this approach, as molecular radiotherapy, how I call it, is applied based on the molecular phenotype of the patient. For example, PSMA expression of the tumor or the metastases, and this can be defined by PSMA PET-CT imaging. So if you look at prostate cancer, it is one of the most frequent cancers around the world. In the United States, there are 3 million men living with the disease, and the vast majority, of course, of the patients have localized disease, but there are also many with spread to the lymph nodes or to other organs, especially the bone. So 1 out of 6 men will be diagnosed of prostate cancer, 1 out of 12 will be suffering, and 1 out of 25 men will die of the disease. And to make this number a little bit more transparent, if you look at the European Union, about every 12 minutes a man is dying of castration-resistant prostate cancer. So there is really a need. And of course, you know the different phases of treatment of localized disease is radiation therapy. I was very impressed yesterday to see your approach of SBRT. Of course, surgery is another approach, but there are many different methods to treat the primary tumor, and this is a battlefield actually. And then if the patient develops metastases, he usually receives hormonal therapy, LH-RH analogs and so on, or one of the newer drugs, abiraterone or enzalutamide. And then in a more advanced stage, metastatic disease, the disease is treated with chemotherapy, mainly with docetaxel or cabazitaxel. But unfortunately, today still all these patients die after some time. And this is again from the Journal of Clinical Oncology, showing you the results of the most important studies. And the results, to summarize it, is that chemotherapy gives you a survival benefit of just a few weeks. And even second generation anti-hormonal therapy gives you 3 to 5 months in addition, but also adverse effects in some time. And the progression-free survival is 16.5 to 18 months, and overall survival 14 to 32 months in early stages of the disease. Though there is an urgent need for more effective therapies. And I just would like to show you one insert of docetaxel. And if you look at the adverse effects, especially hematological adverse effects like neutropenia in 84 to 90% of the patient, you can imagine that especially in older people, okay, there is a big problem with chemotherapy. And this is cabazitaxel with a benefit of 2.4 months in overall survival compared to mitoxantrone and prednisone. So novel therapies have shortcomings. Some are available only in the United States or Europe. PSA is really not the best marker to monitor the disease, especially in undifferentiated tumor. The therapy sequence is not clear at all. So if you go to Johns Hopkins or to Memorial Sloan Kettering, okay, you find quite different approaches when to use what and in what combination. And this is also the case in all other departments around this country and in Europe. Okay, there are no studies showing that at this time the best agent is abiraterone and later on chemotherapy or combinations. So this is left to the experience of the uro-oncologist. And then there is also toxicity, as I have shown, organ toxicity, but also financial toxicity, because some of these treatments are very expensive, like immunotherapy with cipuloxil, for example, is over $100,000, $200,000 easily, and not many patients can really afford this kind of therapy. PSMA, on the other side, is a cell surface enzyme that is continually internalized. It was actually invented and first used by the group from Marty Pomper at Johns Hopkins, and it has glutamate carboxypeptidate 2 activity. So this should be the right name for this compound. But everybody is speaking about PSMA because it sounds similar to PSA probably, but it's completely different, and it is not prostate cancer specific. You will even find it in breast cancers, in pancreatic tumors, in renal cell tumors, and so on. So it is GCP2, and it also has folate hydrolase activity. And it was just recently, a few weeks ago, a paper appeared from Marty's group, by the way, from Johns Hopkins, showing that it is a growth factor, right? Like other growth factors we know. So it supplies the tumor cell with very important vitamins like vitamin B, like folate, and so on. It's a very exciting story which is now ongoing. And clinically, it is important that it is expressed in higher grade tumors and metastatic disease. And as you can see, it has an extracellular compound and an intracellular compound, and is a transmembranous enzyme. Okay, so if you ask in how many cases of prostate cancer it is expressed, you find the answer here. These are over 900 patients actually studied by immunohistochemistry, and Neil Bender was really one of the essential people to do these studies. And you can see that as higher the Gleason score, as higher the PSMA expression, and that it is really not expressed in benign prostate hyperplasia, which is completely different from choline or many other tracers which are used for imaging. This is showing you the three-dimensional structure and the glial cell here and the enterocyte, okay? And you see that the PSMA and the NAG enzyme in the brain have very, very great similarity. And this is why Marty actually found this compound, because he's a neuroradiologist and trained as a chemist also. And he saw this chemical similarity. And this is showing you a very nice three-dimensional structure where this urea ligand is really fitting into this pouch of the PSMA enzyme in the cell. So for imaging, for PET-CT, we can use it for primary diagnosis. And I will show you one example. This is a patient with a high PSA of 50, okay, worrying about having prostate cancer. We did imaging, and you see there is no significant uptake in the prostate. And it was just prostatitis, chronic prostatitis. And we know now the follow-up after about 5 years, he has no tumor, but just a big prostate. Controversy to this patient who had a biopsy because of just 8 nanogram per milliliter PSA in serum. And the biopsy was negative, but PSA was rising. And he came to our center, and we imaged him and found localized cancer exactly at this site where the prostate biopsy is usually failing. And then we did a PSMA-directed biopsy and confirmed the Gleason 9 tumor, and he received radiation therapy thereafter. This is, I think, very, very interesting for those who are doing MRI. One can, of course, combine PSMA, PET, and MRI, either as MRI PET or even as image fusion. So you do not need the hardware. You can do the PSMA PET CT and the MRI and combine the images, and you will get the same. But it shows very nicely that you can combine multiparametric imaging and PSMA, and you really find the uptake in the tumor lesion with the highest malignant potential. And this is very, very important, and this is one of the difficulties of multiparametric MRI, which is a wonderful method, but is very difficult to interpret sometimes. So initial staging and detection of lymph node and distant metastases is another indication. This is a Gleason 9 prostate cancer operated 1 month ago with a operative PSA of 0.37. So R1 situation. So what would you do? Everybody can make a decision on that. The urologist actually decided before EBRT to send the patient to our center to look if there would be lesions outside the prostate bed, and you see the result here. So it's not only one lesion, it's actually, if you count 14 lesions we detected in these patients. I will show you some very small lymph node metastases at this year, just 3 millimeter in size, even normal or a little bit just enlarged on CT scan. You see it very, very clearly, okay? So if you ask your resident reading these images or someone with 10 years experience, you will get the same answer. Okay, it's not like, okay, like FDG might be not or so. It's a very high sensitivity and specificity. And astonishingly, this patient had also bone metastasis with a PSA of 0.37 nanogram per milliliter. And this is a systematic study done at the Technical University in Munich, looking at PSMA PET compared to what we call conventional imaging, so MRI and CT scan. And you see that the sensitivity was about 50% higher for PSMA PET versus conventional imaging. It's also a big advantage that you have a one-stop shop method. Okay, you need not 3 or 4 different procedures to stage the patient. You can look at the primary tumor, which is here. You can look at bone and lymph node metastases, and you can also look at lung and liver and so on in one procedure, taking in our center around 15 to 20 minutes. And you have all the answers you need to proceed. And what I think personally is a very big advantage is that we can, for the first time in history, now really very specifically diagnose bone marrow metastases. So even in patients where the corticalis structure is completely intact, you would see nothing on skeletal scintigraphy in these cases. And you do not see even on CT changes, only in the marrow. We can easily detect bone marrow metastases. And I would like to give a word of honor to David Kuhl, who worked not far from here in Ann Arbor for many decades of his life. And I visited him in the 90s when Richard Paul was working there. And he was really a giant of science and died, unfortunately, last year. And this is David Kuhl as a young man in 1962 in the first scanners which were built, the Mark II, showing very nicely the principle of positron emission tomography with the 2 detectors. And all this electronics, which filled another room, actually is today on a chip, right? So times are changing. And times are changing, and I think the PET scanner of the future might be the Explorer, which looks not only at one bed, but at the total body of the patient. It has a very increased sensitivity, as you can see here, 40 folds in adults, for example. And the imaging time will come down to 15 to 30 seconds. And this is a revolution as compared to the half hour we have nowadays, and will enable not only to do over 100 PET CTs per day, with better image quality and better temporal resolution and so on, but also with lower radiation dose. And this is another very interesting feature for you here in Grand Rapids because of your children's hospital, I have seen. And many of the patients need sedation today for doing PET-CT, which will not anymore be necessary when using the total body PET. And also, as you can see here, the radiation exposure will be much less in these patients because you can image the patient within actually 15 to 20 seconds. So theranostics, of course, for me is the most interesting application of this device. And this is a current status. So I just heard 3 days ago that now at UC Davis, the first Explorer has been established. And Simon Cherry, who is a physicist and have developed this concept over the last 12 years actually, received the Paul Ebersol Award of the Society for his achievements. And we very much hope to get the second, and maybe you get the third Explorer here, but I want to have the second. Okay. Diagnosis of recurrence after primary surgery is probably the most frequent indication for gallium PSMA imaging. This showing just one patient with a single obturatory lymph node, and he received surgery, but one could have also done SBRT, stereotactic radiation therapy, in this patient, and was cured from the metastases. And then again, molecular radiation therapy planning, something we started more than 10 years ago, at that time using F18 choline. Nowadays we would use PSMA with a lot of possibilities, and this is a very nice recent publication showing a three-dimensional map of PSMA positive lesions outside the standard radiation field. And you immediately see, but just looking at the image, you know, what is the impact of this method if you are doing really radiation therapy. So the future is now, and there are now also new molecules like the twin tracers or radiohybrids, where you can use the same molecule for F18 imaging or for gallium-80 labeling, and you get the same results if you compare here the F18 labeled compound with the gallium labeled compound. You see that the images are really identical. Let's say if you have a big center with 20 patients per day for PSMA imaging, you would go with F18. If you are a small center anywhere in a smaller city, you can use gallium with the same tracer, which I think is fascinating. So the key points from the imaging is that elevated PSA without tumor detection might be in some specific patients an indication. Initial staging is very interesting, of course, for the surgeon. Detection of recurrence is the most frequent asked question. Therapy monitoring, molecular radiation therapy planning, and finally theranostics. So if you look at the conventional treatments, you know, they're like a bushfire, okay? Hitting not only the tumor cells, but also normal cells. And we want to have a very precise approach for radionuclide therapy. And the German Nuclear Medicine Society must be congratulated for the fact that they were the first in the world to create a consensus guideline for this kind of treatment, which was actually published as a multi-center trial in the Journal of Nuclear Medicine. And I would like to focus your attention to this chart here, which show that, again, improvement of pain and quality of life is a very important feature. So as you mentioned in your introductory words, there were patients coming in a wheelchair, not able to walk because of pain and widespread disease, and after 1 or 2 treatments, they were driving with their own car. So this is, if you are really a doctor, if you are dealing with patients, this is an enormous motivation to proceed the field in this. I do not want to speak a lot about dosimetry because I know most of you are not nuclear medicine physicians, but just to mention that we have done nearly 1,500 dosimetry cycles in more than 900 patients over the last year. So we have a lot of experience, and this is just one slide for those who are asking what is the dose in tumors. you can achieve. As you can see here, this bone metastasis receives 467 Gray. Okay, so we can get several hundred Gray with lutetium PSMA in tumors. At the same time, if you look at whole body, 0.3, really nothing. So you do not have really a high radiation dose to normal tissue. This is a first paper we published in 2016 after we started treatment in Bad Berka. I think we were really the first center using lutetium-177 for treatment of prostate cancer in April 2013 with a median progression-free survival of 13.7 months. And if you look at the results of this patient with abdominal lymph node metastases, we could cure these patients from the lymph node metastases at that time. And this is another patient from this first series with widespread disease. Just again mentioning that PSA is not a good marker for undifferentiated prostate cancer. So this patient had 0.05 nanogram per milliliter. And when we showed the images to the urologist, he said, "Oh, I don't believe that. That must be, lung cancer or something else. I have never seen this." But it's a fact. We have now at least 50 patients with a PSA of less than 0.05 of less than 1, okay, and widespread disease. So we treated him with 3 cycles, and what you see here are the lutetium scans under therapy. So lutetium is not only a beta emitter for treatment, but it also has a gamma compound, so you can very nicely image this patient under therapy and immediately look what is the effect of therapy. And this is then after the 3 cycles, and there's complete remission of the disease. So again, low PSA does not mean low tumor burden. Many uro-oncologists think, oh, okay, this guy has just 1 or 2 nanogram per milliliter is, nothing. But if you look at PET-CT, you will see that PSMA is really expressed in those undifferentiated tumors with low PSA. Now, what about the response? Usually you take PSA. Now, if you have 0.05, what would be your response? So you need molecular imaging for response. And we did that, and measuring, for example, the SUV on the PET-CT. And already now 8 years ago, we presented our work for automatic detection and automatic analysis of molecular PET-CT image, by the way, with another Nobel Prize winner, German Gerd Binnig, who won the Nobel Prize for the tunnel microscope and was helpful in developing this technology. So again, economy of time. If a doctor, an MD, is sitting for half an hour in front of these images, getting all this ROIs and so on, it's just stupid. I mean, it's wasted time. And our conclusion at that time was that this technology seems to be extremely promising for shortening the analysis time, for improving precision. I was already using precision and reproducibility, well as increasing sensitivity in lesion detection. And I'm very happy because unfortunately we had to give up this project because the Fenians was actually drawing his attention to someone else. We have now a very nice collaboration with Anthony and Rethink Imaging, and I would like to thank Anderson especially for getting these images, where you see this is an automatic detection algorithm, and it's even more sensitive than our eyes, because if you look at the lesions here in liver and in the spine and skull, you see there are 19 lesions in the pelvis, 21 in the bone, and if you remember the original image, and our analysis was not as sensitive as this automated analysis. So I think, again, AI, artificial intelligence, will become very, very important, not only to save time and to count all these lesions, but also to be more precise, to have data on what is the tumor volume in lymph nodes in the bone and in other organs, and then do a more precise and patient-oriented therapy approach. So these are the numbers of the patients with prostate cancer. We have treated 254, 762 treatment cycles. And you see most of the patients had received 3 cycles, but some patients up to 11 cycles over the years. So this is not a treatment like chemotherapy where you give 6 cycles and then stop. Okay, it's done, can't do anything anymore. But you can repeat the treatment if the patient has progression or recurrence. These were really heavily ill patients, all progressive before treatment with a mean Gleason score of 8. And you see most of these patients had failed androgen deprivation therapy, had been operated or had received chemotherapy or radiotherapy before. And again, if you look at the metastasis, site of metastasis, most patients had bone, but there was also a very large number of bone and lymph node and combinations of this, and lung and liver and rare metastases like in the adrenal gland, for example. This is an impressive example of a patient in November 2015 presenting at our center with some lymph node metastases. You can easily see on this MIP image. So he was castration resistant, had a Gleason 8. He had received surgery and external beam radiation therapy in the pelvis, and as I mentioned, also hormonal therapy. So the oncologist actually recommended to continue the ADT and to add external beam radiation therapy, which might be not a bad idea. I mean, it's just localized disease. But look, in November 2016, so 1 year later, the disease had exploded and was now in all the bones and in more lymph node metastases and so on. And we started to treat the patient with 2 cycles of lutetium PRLT, and fortunately enough, he went into complete remission of the disease without any adverse effects. And this is a very important feature. So no hematological toxicity, no renal toxicity, and complete remission of the disease. These are the lutetium scans under therapy, 20 hours, 70 hours, and I could show you 3-week scans after therapy. It's still sitting in the tumor and all the normal organs are clean, okay? And this is under the second treatment, and you immediately see that also the lutetium images under therapy can be used for follow-up of this patient. Now, what about PSA response? Is such important parameter for oncologists. They always ask you, what about PSA, okay? I think it's not so important, but anyhow, we did the calculations and we found a decrease by more than half of the patients in 54%, which is nicely shown by this waterfall plot here. Safety analysis, my highest concern at the beginning was the kidney, because the kidney is so prominent. You really see the black kidneys, and but fortunately enough, we have seen no nephrotoxicity at all. Okay, even after now 5 years in some patients of follow-up, we have not seen any toxicity, and even in 17 patients with a single kidney we have treated, there was no nephrotoxicity. So it was very well tolerated by the patients. Many patients left the hospital asking me, have you given me water? I don't feel really anything. So it's very well tolerated, except for those with very widespread metastases and a high tumor burden, where short-lasting mild fatigue is the most common immediate side effect. And the salivary glands, xerostomia, we find actually in less than 3% of the patients. So again, to remind you of the success of chemotherapy and hormonal therapy is limited to a survival plus of around 2.5 to 4.8 months. And these are our data. Progression-free survival in this large cohort is actually 9.8 months. And more important for me, and the most important parameter, is really median overall survival, which is 2.5 years. In these patients, mostly heavily pretreated, sometimes even as a last-line therapy. So this is another example of a 62-year-old internal medicine specialist. He unfortunately was hormone resistant and had to give up his practice, but he refused chemotherapy. Why? Because his wife had breast cancer and he had seen all the adverse effects of chemotherapy, and he said, no, I do not want to have this. And we treated him with 3 cycles, as you can see here. And again, good for him, we achieved complete remission of the disease. His PSA declined from 356 to 0.0, and this was October 2016, and he could restart his practice and even started playing tennis again. And half a year later, or 9 months later, actually he was still in persistent complete remission, and he will return next week for another scan, and his PSA is still 0. So this is very, very encouraging that at least in some patients the response is lasting quite a long time. Now you might ask, what about earlier treatment? Because if you do not have adverse effects and so on, we probably could move the therapy more upfront. And this is what we presented at the meeting of the society in Philadelphia, which was actually finished, I think, yesterday. And to make a long story short, we can use de novo or first-line PSMA radioligand therapy for metastatic disease. It is safe, it is effective. As you can see, the median PFS was 30.9 months, and OS is not reached in this patient group. And we might combine it with some androgens which enhance PSMA expressions like enzalutamide, for example. This is one example of a patient from your home country, from Taiwan. He actually is a dentist and has a huge practice in Los Angeles with 20 doctors running the business. And he said, I do not have time for operation or radiation therapy and so on. And chemotherapy I do not want. So he had, as you can see here, primary tumor, a large lymph node metastases, and also smaller metastases along the aorta and the vena cava. And we treated him with 2 treatment cycles, and you see there is progressive decline of the disease in this patient. And he was not 1 day in hospital except for the treatment, because in Germany we are forced to keep the patients for 48 hours at our ward. What about the future? I think there are many new radioisotopes which are interesting, and one, I call it the Swiss Army knife, is actually terbium. As you can see, terbium has an alpha emitter, 149, which can be also imaged by PET, very exceptional. 152 terbium is a long-lived PET tracer. There is a electron capture terbium 161 and also a SPECT imaging tracer. So this is very, very interesting for pre-therapeutic dosimetry and radionuclide therapy. And we got actually terbium 152 produced at the CERN, okay, which then went to the Paul Scherrer Institute for processing, and then over 3 customs, French, actually Swiss and German customs, to our center, which was really a logistical hurdle, but we managed it and injected the patient and did some very nice images. And I'm mentioning this because I heard yesterday that there is a big synchrotron plant not far from here, which could probably produce terbium for you, and that would be exceptional, not only in the United States. I would like to finish my talk with targeted alpha radiation therapy, or ART. Now, alphas have a much higher mass than betas and a linear energy transfer, so destruction potential, which is 100 times greater than the betas. And the first studies this time did not come from Bad Berka, but from the German Cancer Research Center in Heidelberg. And they published their first 3 patients in the journal in 2016. And you see that even patients with progression under lutetium therapy after 3 treatment cycles with the actinium, with the alpha emitter, went into a complete remission. So one can dream of curing the incurable. And these are data from South Africa showing it's not only working in Germany, it's also working in Pretoria in a patient with huge lymph node metastasis, bulky disease, 2 treatment cycles, and complete remission. And believe me, it's not Photoshop they have used in this case. Now, one of the most significant adverse effects of this actinium alpha therapy is destruction of the salivary glands, okay? And we were trying to find a method to avoid this damage to the salivary glands by injecting actually botulismus toxin. And you see a patient here before and after. On the right side, we injected the Botox, and there was a significant 64% reduction in uptake. And we were very grateful to Anthony helping us to get these images published by a very nice 3D rendering image we obtained here. And this is one of my last slides, just showing you what we are doing now. So by trying to reduce the dose to the salivary gland, we went to 50% of the alpha emitter and added 50% of the beta emitter. So this is what we call tandem therapy. Okay, so we give lutetium and actinium on the same day in combination. And this is one of the first patients we treated, progressive under lutetium therapy. So we do not have always this complete remissions and super success, okay? So in 15% of the patients there is progression despite lutetium treatment. And as you can see here, after a single shot of this tandem therapy, the patient went into complete remission of the disease, which is really amazing. And also this patient from Russia who paid more than $100,000 for proton beam treatment without any sense, because he was, as you can see, quite heavily metastatic, was progressive under treatment, received 1 single cycle and had a very good response to this tandem therapy. Now these results are not only discussed now in the nuclear medicine community, but also by the oncologists, which is very, very important. So we had a meeting in New York last year from the Prostate Cancer Foundation, and you see the most eminent institutes of this country were present, and you know, this new approach was taken very positively, and I think we need actually trials to prove this. So to summarize, PRLT is effective even in end-stage disease. It significantly improves clinical symptoms and prolongs progression-free and overall survival. Most patients tolerate it very, very well. There is no or minimal hematotoxicity in chemotherapy-naive patients, and there is no nephrotoxicity at all, and salivary gland toxicity is around 3% or less. Most important, we can select these patients according to the theranostics concept by PSMA PET-CT, and in future we might combine the beta and the alpha emitters. We will look at new radioisotopes for imaging, especially F18 radiohybrid PSMA. We can combine it, and this is very important for our urological colleagues with other treatment, and find the best place for this treatment. And what we need most urgently, as I said, are prospective clinical trials, which fortunately have now started in Australia. The therapy study, which is a randomized comparison of lutetium PSMA 617 versus cabazitaxel, And I'm sure this race will be one of the radioligand therapy, but it must be proven in a prospective way. So I would like to acknowledge all our national and international collaborators, radiochemists, physicists, biologists, and so on, and also my Bad Burkhardt core team, how I call it. We are not really a very huge team, but I think we can do things effectively. And I also would like to thank again Anthony and your team for joining this effort. And I'm sure we will have some very nice collaboration for the future. I would like to finish with a man who did establish a whole industry not far from here, Henry Ford, who said anyone who stops learning is old, whether at 20 or 80. And anyone who keeps learning stays young. And the greatest thing in life is to keep your mind young. And I think this is absolutely true. Thank you very much for your attention. If there are any questions?
Yeah, thank you, Dr. Baum, for the talk. Any questions?
Next time, Dr. Baum. I'm intrigued with your integration with intelligence. I think
Yeah.
that the idea that we can bring the technology that would help us as visible to us. I was amazed with how spectacularly conspicuous the lesions were. It sounds like there's still room for improvement. Where do you see the changes most as far as the AI interface?
I think radiomics is a big issue, and it was now mainly applied for CT and MRI, but we are also starting using it on PET-CT. And we have just very limited experience in that, but there are studies done, for example, in Maastricht by Philippe Lambin and his team, showing that if you extract this information by intelligent algorithms from even simple FDG images, you can better prognosticate the patient, saying, for example, in lung cancer, this is a more aggressive tumor, not only looking at the level of standardized uptake value, but also at radiomic features. So yes, I believe there is a great potential, but up to now there is no study or practical data showing really the benefit for the daily routine, right? But I'm sure it will take some time, and these studies will be done, and single center studies already show that you get much more information out of these images than just looking at the images. Yeah, please.
First, I want to celebrate your journey, and it started with the patient, and I really appreciate your focus on quality of life and transfer. I'd also say that maybe the best lecture I've ever heard. It was just
wow. Thank you. Yeah.
I know you're very passionate, you mentioned in the slide, learning.
Yeah.
About also the educational component that could be attached to this great effort.
Yeah.
Perhaps comment on that?
Yeah, thank you very much for this question. I left this out because of time reasons. I'm anyhow a little bit over time probably. But I think this is one of the most important issues. If you are starting theranostics, you must have people knowing about the technology. Starting with very simple things like radiation safety, physicists training for dosimetry and so on, but also for the doctors. I think it's not the right way that nuclear medicine physicians send their patients to the oncologist to take care of the patients. It is really the task of the nuclear medicine physician to do that. And that was always my principle over the last 20, 25 years, to be in contact with the patient, to take care of the patient. And the best one to do that is probably in future a different kind of specialty, which I call precision medicine specialist. Not anymore nuclear medicine or oncology or so. So a person really combining this knowledge, from genetic analysis, from many tests which will be available in future to characterize disease on the genome level, but also on the imaging level. And a person really combining this in a useful way for the patient would be a precision specialist. And these people need to be trained in some way in radiology, in nuclear medicine imaging, okay, but also in therapy. And I would really like, thank you again for the question. I mean, it's coming from our heart, because I think we really have to found something like Theranostic Academy, or Academy for Precision Oncology or something, to really establish this in a structured way. So not by chance you are going to this department, oh, you are lucky, you learn it, okay? But in a systematic way, training the young generation, and even starting at the undergraduate level and not, at the specialist level, really training this patient, what is precision oncology, what is theranostics, and how can it be achieved in a structured way. I think this is one of the most important tasks. And I mentioned that I was in Philadelphia at the Society of Nuclear Medicine meeting, and I'm a member of the Therapy Council of Excellence, how they call it. And I was really shocked to hear from my colleagues in the United States, that now that Lutathera is approved for neuroendocrine tumor treatment, in some departments, the nuclear medicine physicians are just, injection guys. They just administer the activity and the patient goes in the oncology department. I think this is not the way to do it. We really have to train oncologists, radiologists, nuclear medicine physicians, genetic specialists, to combine. This is a new field, okay? And I think your previous president made it right to give some money for precision medicine. So it was, I think, not enough money. The initiative should be taken up again with more financial power. But anyhow, I mean, it was the right way to show we are going in a new direction. But we need the tools, to train people in this area.